Good afternoon again. Thank you all for joining us this afternoon for our April training, HIV among older adults and related social determinants of health. My name is Karan Phillips. I am a policy development manager with Trust for America's Health, and I would love for my colleague Megan to introduce herself as well.
Hi, everyone. Welcome. I'm Megan Wolf, Senior Policy Development Manager at Trust for America's Health, and we're very happy to welcome you to this really important presentation today as part of our series, Friendly Public Health Systems. Karan, back to you.
Thank you, Megan. Just a few logistics. Please keep your devices on mute. There will be time to engage with our presenter after the training. If you have any questions during her presentation, please place them in the chat. Again, there will be ample time at the end to have a rich Q&A discussion with our presenters. Please feel free to put your questions in the chat throughout the entire presentation. We also have closed captioning available for this training. That option is available to be enabled on the taskbar as well. So without further delay, we'll let her turn over her slides in just a second, but would like to introduce our speaker for today, Ms. Dorcas Baker with the MidAtlantic AIDS Education and Training Center at Johns Hopkins University School of Nursing. She's also over the Maryland Coalition on HIV and Aging as well. And so we're excited to have her here today to share her experience and knowledge about this very timely and important topic. So Dorcas, I will turn it over to you.
Okay, thank you, Karan, and good afternoon, everyone. I certainly want to thank Megan and Karan for inviting me to have this important talk with all of you on today. And I'm really grateful for age-friendly public health systems and Trust for America's Health that this topic can be discussed. So I'm going to go right ahead and share my screen, and so we can have plenty of time to move through this particular issue. And it's very, very important, as you will see as we move along. So I'm calling it HIV and Aging, a Changing Landscape, because this is a major changed landscape, a disease or an infectious disease that has gone from a death sentence to a life sentence. I'm going to put this in PowerPoint mode so you can see the slides better. Let's see if that will work. There we go. Okay, and move you all over to the side so we can see one another. Okay. So my objectives is to at least cover some of the epi about HIV in older adults and why this landscape of change has come about and why it's so very important, and go over the impact of social determinants of health and discuss what can be done to improve the overall health outcomes for this population. So if you look at this slide, this is just in general, it's showing you what has been predicted about people living longer with HIV. We didn't know this would happen. This is my 30th year of working in the field of HIV and coming on board where there was a lot of death at the time that I started working in 1992, and it was already here in the 80s. But it was predicted that people will live longer with the right therapies, and that has come about. So we are even, if you look at the chart for persons over the age of 50, in 2020, it was predicted that we'll get to 70% by that time. We're sort of vacillating right in between that. The biggest thing is people that I want to get across is aging. People are living longer with HIV. And this is the first cohort of individuals that we've seen, because it was a death sentence, but it's a life sentence now. So many are in their 60s, 70s, 80s, and there are a few in their 90s. But we have come a long ways with this, and it's still preventable, and there are still new diagnoses as well. But the biggest piece that's happening is people are living and not dying with HIV. Just quickly, just a little bit more, showing you some HIV diagnosis among people age 50 and older in the US. And the report is from the CDC, and they're like behind a year or so. It's always like that until we get the new surveillance report. But just to show you what some of the transmission categories are when we look at men over 50 and women, 50 is like the artifact number that they use for aging or older. And for men, male to male sexual contact seems to have been the biggest transmission category. And for women, it has still been heterosexual contact. And when we look at HIV incidence, new cases and prevalence, those living with, in the red bars, the blue bars, you can see new diagnoses are definitely increased in our 25 to 34-year-olds. That's a higher bar. But as people live longer, the red bars are showing people with HIV that are middle age and living longer. I have a new slide from even our Maryland data, and you can probably check the states that you're in, and you'll probably see the red bars even a little higher. But regardless, this is a life sentence. People can live longer, and including 65 and older. So this is still evolving. And this is showing you again, HIV cases in the United States. If you look at the middle age category, those 40s and up to 59 and all, this will continue to grow because people are living with treatment. And even those that are younger, if on treatment, they will also live. So this is a growing population of aged individuals. So why is it changing? Well, therapy has gotten much better, particularly in 1996, when we came out with a class of meds called protease inhibitors. It increased the lifespan. And we began to see this turning from death to living. And this is, as I said, the first cohort of aging individuals. We weren't expecting people to live long, so we weren't looking at aging. And it has been overlooked, except for the past maybe 10 to 15 years, really starting to deal with it. And older adults are also included in new HIV diagnosis. That won't be my focus completely today on prevention, but that's very important. We have individuals being diagnosed with HIV. That 17% of all new cases of HIV are in older adults. And this has been steady since like maybe 2015 or so. The larger percent, those that are already living with HIV. And we do teach prevention, and that's another whole great and fun talk about sexual health in older adults, okay? And among people age 55 and older who received an HIV diagnosis in 2015, 50% had HIV for at least 4.5 years before they were diagnosed, because again, we weren't looking at HIV in older adults. They are living, but they are also sexually active as well. Prevention and STIs, these things happen in older adults, and education about that was a big deal, but they weren't being asked about sexual activity. We tend not to ask. The older the individuals are, providers do not always ask questions about what's happening below the waist unless you've had prostate. Have you had that done, your prostate exam? Have you had your pap smear? Questions like that. So we are doing better now with asking everybody, doing routine HIV screening to make sure we're not missing anybody, because they are and can live long lives with medication. So why is it changing? Older people include many long-term survivors who've lived with HIV for more than 10 years. And some long-term survivors, they say thrivers, were diagnosed before we had improved treatment available in 1996. Some may be under the age of 50, including persons living with perinatal transmission. There is a population of young adults in the United States that were born with HIV. The oldest that I know is personally are 3 young women, 36 years old, but 36 years of living with HIV. And that's a long time. So HIV was declared a chronic disease in 2012 by Kathleen Sebelius, because we found out, we knew then that, wait a minute, people are living. This is a chronic condition, preventable, but if you have HIV and you've had it for a while, or you're just newly diagnosed and you start treatment, you will live with this condition along with other chronic conditions that the individual may have. So that put it in a totally different light. Many people are not even aware today that HIV is a chronic disease. So HIV and aging matters. America is aging, as you all know, and quality elder care is lacking even in the general population. So comorbidities among older persons with HIV, that's increasing because living longer, and by HIV being a chronic disease, as well as inflammation, that can trigger other comorbidities as well. And these syndromes can be seen before an individual is chronologically older or elderly or senior. We have to get rid of those terms and use age-friendly terms. 65 is the new 75, but they can be seen earlier, like even in individuals that are younger adults, but they've lived with, that were born with HIV. We cannot forget that population as well. And they may have these syndromes seen before they even reach their 60s. So I put it in red: identifying factors early that may lead to disability and social isolation will help prevent and slow down disability, just like we wanted to do for a general age population, and improve the quality of life. Isn't that our goal? And it requires the attention and the expertise of providers from multiple healthcare disciplines, not just HIV providers, not just infectious disease, but primary care, those caring for older adults, geriatricians. We'll go into that a little bit later. So this is just a chart. I'm not going through it to show you that comorbidities increase commonly with people with HIV as they age. And as they age, you'll see they have more and more comorbidities. The same: hypertension, hyperlipidemia, renal issues, COPD, diabetes, osteoporosis, things that happen as individuals age. But with HIV, they have the same thing. And what's important with the older population, we want to deal with making sure that the virus stays under control, and it does. They do very well with adherence to medications. We're suppressing the virus. It cannot be transmitted when it's undetectable. But these aging issues, just like other adults aging, hearing, vision, cognitive issues, polypharmacy, social isolation, depression, I just stopped the list, but there are more. And as I'm doing this talk, you will see, even before I get to the social determinants of health, some of the things being said, you will know what that's like. That's one of the social determinants of health. It's very important that we are aware, with the population living long and basically doing well, other than aging issues, we don't want to interrupt adherence. We want them to continue with medications, which they will have to take for a lifetime. We do not have vaccines yet for HIV, but people can live long lives with HIV. And then I want to introduce a little bit about geriatrics. Who would think that we would be talking about a geriatrician or gerontology with HIV? We didn't know this 30 years ago or even longer. HIV has been around for 40 years. We just celebrated the 40 years of HIV with the National HIV/AIDS Awareness Day. But older adults can benefit from the models of integrated care. Geriatricians focus not on disease, but on function, how to enhance the quality of life. And I'm an advocate for older folks living longer with HIV to continue to do that. And this is the first cohort. I'll say that a lot of times. There is an example of a clinic. It opened in San Francisco in 2017 by an infectious disease doc, and she is also a geriatrician, and they started doing consults in their clinics with their HIV patients. Diagnosing and treating comorbidities is just not enough to address their complexities with aging with HIV. And I know those of you that may work in gerontology, or you're geriatricians, or you're familiar with the 5 M's of geriatrics: the mind, how do we work with our patients and do interventions to determine early what's going on with these. I don't have to read each and every single one of them to you. Mobility is important. Are they walking? Are they safe? Are they at fall risk? Are they exercising? Multimorbidity, that word again, the management of multiple chronic conditions. And polypharmacy, taking medicines to treat HIV and the other comorbidities that they may have. And is the physician or the nurse practitioner or the PA aware of drug-to-drug interactions that can happen when you're taking multiple medications for different conditions. And what matters most, that patient's health outcome goals and care preferences are most important of the 5 M's of geriatrics. And of course, we deal with their activities of daily living, just like you would with anyone that is aging or maybe living alone, or are they in a facility, or where are they? Are they aging in place? All of these things are very important because we want to keep folks in their home if they're safe, or keep them aging in place as long as possible. So that's not different for those that are aging with HIV, but we want to make sure we are addressing these. No longer can the infectious disease doc say to their patients, well, you're older now, that's probably why you're experiencing this or that. But that's not the final answer. Now that you're older, you can still have great quality of life, and they may not be the experts in aging. So why not bring in experts that are like our geriatricians? And the polypharmacy, we know older adults receive a lot more medications than really necessary. And sometimes we fail to evaluate, do you still need this antidepressant or this particular one, or what medicines can we cut down? Deprescribing in aging is a big issue anyway, looking at benefit versus harm, and realizing all these other disease states that may be happening. And our HIV experts may not have training in geriatrics or know about the drug-to-drug interactions, and vice versa. The geriatricians may not understand, oh, wait a minute, you're taking HIV medicines. Let's see if that's going to interact with what I'm going to prescribe for your kidneys, or for your heart disease, or for COPD. So it's a lot of partnering and collaborating, and really making sure we're communicating. This is just showing the chronic medication count. The veterans cohort did a huge study, and they're still following 47,000 individuals, just showing that those with HIV as they age have more medications than those that do not have HIV. So the common issues among older adults, difficulties in accessing and maintaining health care, managing their HIV care, gaps in the health professionals' knowledge, experience, and sensitivity. And this is where the AATC comes in. I've been with the AATC since 2005, and our task is to make sure we're providing education, whether it's clinical preceptorships, conferences, one-on-one, webinars, seminars, technical assistance, coaching, to make sure our providers are up to date and understand about treating HIV, as well as collaborating with those that don't know about HIV to keep everyone on the same page. And these other common issues, the lack of programs that respond to loneliness and social isolation. You're hearing some themes that run when we talk about social determinants of health. They can exhibit 3 to 5 times higher rates of depression and socially disconnected. The lack of mental health and alcohol and substance use treatment programs. SAMHSA, a substance abuse and mental health organization, said that alcohol use is really the highest substance that's used as folks get older, as they age. Stigma and discrimination heightened by ageism. I know you are aware of this. And concerns about ending the epidemic. Yes, we want to end the HIV epidemic, where no one is no longer getting HIV. The education is there, prevention is there, the tools are there, but people are still living, and how to have them live with a quality of life. So too many adults with HIV feel their needs are ignored, or that they are a forgotten majority, even though they're growing rapidly, because we didn't expect them to live, and they don't want to be forgotten. So there's this disconnect. What's known about HIV and aging, and the reality that not enough is being done, and the need to sustain, get focused and collaborative advocacy to work along with this. Moving forward, that's sustained action. All people living with HIV, regardless of gender, will receive the care, gender ID identification, or however you want to classify, LGBTQ, all of this. All people living with HIV should receive care and support needed to age successfully. And these are some priorities, but we're going to sort of go into that when I talk more about this social determinants of health. But you can see in these categories, these priorities overlap, right, with social determinants of health. And again, that sustained action that's moving forward. And these are examples of advocacy. With the Ryan White program, it was to help, it's the funding of last resort. And we didn't know people will be living long. So there's a whole new thing about looking at Ryan White funding and how that can help when there are individuals that are older, Medicaid, Medicare, and the population of aging people, period, in the United States, let alone a growing population of those with HIV. HOPWA has to do with housing. And these are some of the policy issues. And the National HIV/AIDS strategy, for the first time for the next 5 years, have included, this is 2022, older adults was not included in the HIV/AIDS strategy when it came out for the United States, I believe when Obama became president. And I'm not going to go through these goals because you'll have these slides too, but they're actually looking at the National HIV/AIDS strategy to look at how we can improve the health of those that are aging with HIV. So what can be done? I keep saying it, recognize this is a big shift. We did not know that we'll have a growing population that's living longer. Identify whatever the gaps can be and develop interventions to close these gaps and come up with models of successful aging with possible prevention and intervention strategies. What can be done? Building a multidisciplinary team, interprofessional relationships. This is going to take everyone. We can't operate in a silos with growing population of older adults, period. And in particular, this particular population, because their care is complex by taking HIV medications. So all of these, and there, everybody's not on that list, but it gives you an idea of what can be done. So how public health can promote healthy aging, Area Agency on Aging, promoting equity. And we know COVID revealed a lot. Health disparities were there before COVID. Working with the social determinants of health, 80% of health outcomes are determined by social and economic factors. Health outcomes such as mortality, morbidity, life expectancy, healthcare expenditures, the health status of individuals, the functional limitations, strengthening partnerships like we're doing with AFPHS Public Health, Trust for America's Health, Area Agencies on Aging. How do we collaborate and include this population in the aging population and reduce medical cost burden? I like this slide that the CDC uses for social determinants of health. And I was so glad to hear Aaron Guest last month that did the great talk about social determinants of health. And he mentioned that there are different models of it. I think Canada has like 12 categories. It depends on what model you're using, but the basic social determinants of health, conditions where we know people are born, they grow, they live, learn, work, play, and age. And just because you're born somewhere, you may not stay there. You may live somewhere else as you grow up. You may not learn in the same place where you were before, and this changes. But regardless, social determinants of health are shaped by the distribution of money and power, we know, and these differences lead to health inequities. So if you can see it, education, access, and quality, healthcare and quality, neighborhood, built environments, all of these 5 domains include an awful lot. When you talk about education, you're not just talking about did you complete school, how far did you go in school, but literacy, language, early education, the access. And when we talk about COVID, that's just, that makes it worse. I'm not throwing that in. But the access for education and the quality of that education, it matters. It has an impact. That healthcare and quality, when you talk about that, do you have healthcare coverage? Is there provider availability? The cultural sensitivity, not cultural competent. You're never competent, you're ever learning, but have cultural humility. Is that a part of the healthcare system? And the quality of care when dealing with HIV persons that may feel that stigma or that discrimination or being treated differently. Social and community, we'll talk about this some more, all of these. What support systems are there? Are they engaged in their community? Is there stress just from inequity, stress from not being a part of a community? Are there support groups? What is going on? And there's a category, and you can put it in the chat and we can talk about it later. With all 5 of these, I don't see in this particular model, and it is in others, two that I'm concerned about too is food, hunger, and access to healthy options. Nutrition is a category, and to include with our healthcare and quality research and involvement of everyone in that. So I love this slide that Dr. Guest also used, and I am not explaining it or going through it like he did. He did an awesome job. But I just love that age-friendly public health systems, your 5 C's. And I looked, I said, well, they're dealing with the midstream part of this, because he was talking about downstream is the bottom line, what has happened to the individual. How do we go back and move upstream? What can be done with coordinating and complementing? Then that's when I found your other C. But I have another slide on that. You can talk about it yourselves. But how do we help individuals assessing where they are before, and please forgive that doorbell. I will not be getting it. It's a delivery. How do we prevent knowing what the issues are, these social determinants of health? Does everyone have to plummet all the way down to where they have issues and the risk of falls and the lack of care? How do we get individuals back up and moving up? How do you even stop it right in this area? He did an excellent job. I won't even begin to talk about it. You all know more about that than I, but I love that talk. And then that made me, I said, well, I've got to remember the 5 C's of age-friendly public health systems. Woo! That connecting and convening, you can read it, you know it yourselves already. That coordinating existing supports, the collecting and analyzing the data to help develop interventions and communicate research findings, communicating research findings, best practices, and that complementing. I just love the 5 C's of age-friendly public health systems. I just recently became a part of the dementia-friendly organization in our state, or in our county. And I say everybody wants to be friendly, dementia-friendly, age-friendly. That's wonderful. And let's be inclusive of all. And it's just that working with this population is at my heart. And as an advocate, just to push that forward, that they have the same issues, especially a population that wasn't supposed to live, okay? So that's very important. But yes, the 5 C's. So what can be done? As Aaron Guest brought out, how do we alleviate the downstream adverse outcomes at the bottom, the sludge? How do we identify and address the upstream factors and document and intervene at the midstream, eliminate the adverse upstream cause? So that's your age-friendly language. You know it better than I, okay? But I wanted to just put that in there again about what can be done. I'm not going through this, but this is delicious. I have it as a resource for you. When we talk about successful aging, period, I'm a member of the Association of Nurses, the National Organization Association of Nurses in AIDS Care, and in their journal a few years ago, they put out this great article about successful aging. What does that even look like? And as I looked at some of the areas, it almost looked like a little bit of the social determinants of health, but they were using a biopsycho model. But they looked at the HIV infects for the length of life and what are the preventions and interventions, biological health, cognitive efficiency, mental health. You will enjoy reading this article. And I just wanted to tease you a little bit with that being there, successful aging with HIV? What does that look like? And really, it's not that much different from anyone that's aging, but there are some issues. Okay, and go to the next slide. So what can be done? I'm still asking that question. Let's promote the meaningful participation of older adults at all levels, equipping our clinical and our non-clinical workforce. Remember, I said this is multidisciplinary, it's interprofessional, to work together, not in silos, to care for an aging population. What are the resources for prevention and treatment? How can we do better with messaging? And the social connections through community-based programs. Remember, we talked about social, the community and social context is one of the social determinants of health. But what can we do to help with stigma, trauma, the isolation? How do we leverage technology? Where does that fit on social determinants of health if you use the CDC model? And it may be one of the others, but that is huge, especially now. And maintain treatment access and protection. That's what can be done. When you get a chance, look at this HIV policy in the United States that was put out by the Georgetown O'Neill Institute at Georgetown, meeting the needs of people aging with HIV on the path to ending the epidemic. And you will find in there this great, everybody has 5 things, 5 C's for age-friendly public health, the 5 M's for geriatrics. Now they don't have 5 letters, but I call it DMAP. A greater focus on HIV and aging is needed. DMAP, develop models of care and prevention. You can read the rest. E, expand opportunities for older people living with HIV, blah, blah, blah. You can read that. 3, maintain Medicare Part D, drug access, protections, allocate more funding. This is policy issues. Promote the meaningful participation of older adults with HIV. Many of them are involved in the policy. Many of them sit on boards, Commission on Aging, the very active, strong men and women that are able to deal with this. But when you get a chance, you want to read that policy paper. So in 2018 of July, the work group, we called ourselves the Aging Long-Term Care Work Group in Baltimore was started. We're grassroots, but we called together our aging communities, our aging networks to have conversations about how can we prepare to do better to care for a growing aging population of individuals aging with HIV. And we meet every 4th Friday from 11 to 1. And we now have the name Maryland Coalition on HIV and Aging. Also get a chance to look at the Moving Ahead Together. It's a framework for integrating HIV/AIDS and aging services as well. This was done through grant makers in aging. How do we, what can we do to ensure that we are engaging the population? And one thing that we can do is make sure in all states that they have, if you're an aging network, have you reached out to your HIV networks, whether it's the clinic or a community-based organization, and have they reached out to you so that we can close silos and kind of work together on improving the life of individuals aging with HIV. And for resources, I know I went awful fast, but I wanted to make sure I got through to show you how important it is. Go visit the National Institute on Aging website, and you'll find fact sheets and various things about HIV and how they're looking at that. Of course, I put Trust for America website there. You're familiar with that. The Healthy Aging Through the Social Determinants of Health. I understand it's an ebook that you can get online. This here, the ROA study, version 2, started in New York with the CREA, the AIDS Community Research Initiative of America. And they did a huge study. Now, let me see. Tell me, can you all see this? When you get a chance, I don't know if any of you've heard of it, but this was done, and it's the largest study done in the United States on the quality of life of individuals living with HIV as they age. This was version 2. It was done a while ago, but when you look at this, You'll find a lot of, let me go down to the participants in this particular study, and everything they dealt with had to do with quality of life issues, degrees of working difficulty with tasks and so forth, preparing your meals, doing your shopping, bathing yourself, using the phone. And you'll find a lot of social determinants of health issues were addressed in this. I'm gonna stop that. Tell me what you see when I stopped it.
We see the gallery now, so thank you, Dorcas.
Oh, wait a minute. Oh, okay. Let me slide way down, and I'm just about done. Okay. I'm aging.
We all are. We all are.
And oh yeah, so I'm not going to click any other websites, but I want you to see what's available. And also Older Women Embracing Life is a support group that I co-founded back in 2004 of women living long with HIV and their advocacy and what they're doing. And of course, HRSA's site about the Ryan White HIV program. This is a toolkit that looks at anyone that's caring for an HIV patient. Not all HIV patients go to an HIV clinic. They have providers that may be in primary care who are HIV experts, but have forgotten to look at aging, and this great tool. And I had worked with this to create a pocket guide on geriatric principles and what to do when you have a patient with HIV that's older. And on tomorrow, there will be a webinar by the National AIDS Treatment Advocacy Project, Caring for Older Adults in the 21st Century. It's time for a geriatric approach. And they have great topics. I failed to give you the registration if anybody's interested in that. And so I will stop the share.
Great, Dorcas, thank you so much. About so much information in a very short period of time. So I have a couple of questions that I've saved, but I just wanted to offer the opportunity if anyone would like to come off of mute and show your audio if you're comfortable doing that, and ask questions. So if you want to just come off mute or raise your hand and we could recognize you. And while we're waiting, Dorcas, one of the questions that you posed in the, what can we do, what can be done, was to equip the clinical and non-clinical workforce. What are some of the first steps that folks in the public health audience here, what are some of the first steps that we can take in order to be better equipped to address the needs of people living longer with HIV?
Mm-hmm. I think the first step is to make sure you have reached out yourselves to wherever, like I said, the HIV community, reaching out to the community and those that are caring for the community. So whether it's through a community-based organization, or if you wanted to target hitting the clinics that are actually dealing with HIV patients. And like we did, I think we kind of reached out to one another when I had you all come and speak for my Grant of HIV conference last year. Mm-hmm. I said, age-friendly, Trust for America's Health. Yes, when I was looking at the website and I saw all the work that you want to do, I said, well, they're right on target. Not a silo, but reaching out. And sometimes you can't wait for the community to reach out to you. You have to reach out to the community and find out when they're having their HPG meetings, HIV planning group meetings. I'm a member of the Maryland State HPG, and that's when the state comes together with all the departments, all of the clinics that are involved in treating HIV, and community participants are there because they're representing community organizations. But you're always invited, you're always able to attend those meetings, I believe, in any state that you're in, to hear what's going on, and they will provide EPI, they will talk about the programs and what's needed. And that will be a great opportunity to say, well, who you're representing, and you would love to do whatever you can to work with the population. Mhm.
That's so helpful. And so Mark put a comment in here, long-term survivor syndrome needs to be understood and shared with all HIV providers. National Long-Term Survivors Day is June 6th,
Yes.
2022.
And that's another thing with any of the national days. If you get a calendar that shows you the national, any of them, HIV days, attend or just go to the website and see what's going on for that day, and have that information as well to understand, like the National HIV Aging and Awareness Day, the National LGBTQ, all of them, because we're dealing with an aging population and you want to be familiar. The long-term thrivers, yeah, that's very important. And mental health, reach out to your mental health organizations, but the HPGs can tell you, and the community-based organizations, who would be the stakeholders or the persons you need to speak to, the leadership.
Great, thank you. Thank you so much. That's really great advice. I'm also curious, I see that Tom has another question up here, which I'll let him come off mute if he would like to ask this question himself. But I'm curious, from some of our public health viewers today, do your health departments, I'm assuming that all health departments address HIV and have funding to do that, but are they connected with healthy aging efforts? I mean, I'm just wondering, because public health departments, this is one of their functions, right? And so where are the connections? So I'm just curious if anybody is aware of what your public health department is doing.
Yeah, I'm glad that's a very good question too. So when I talked about the Maryland HPG, I failed to say it's the Maryland Department of Health, where funding also comes to. The Maryland Department of Health and our Baltimore City Health Department, we're closely working together because of funding comes there. But down through the years, we've been together on whatever we can do to address HIV in the population now. I can't applaud them that they've been talking about aging all these years, no, but
right.
They are now. As a matter of fact, for our next 5-year strategy plan for ending the HIV epidemic, we've had meetings, we called them cells, to talk about what can we do with aging. That was one of the cells, and we met 3 times to plot out what's needed for that 5-year strategic plan and the meaningful engagement of older adults. We had for different, populations, LGBTQ, youth, you name it, faith-based, everything. But our Maryland Department of Health, yes, totally engaged in the Baltimore City Health Department. Major partners.
Great. Well,
so you can reach out. You should reach out to your health departments. I failed to say that. That makes good sense.
Absolutely. So Tom's question here, and Tom, I'm assuming since you didn't come off that you want me to ask this question, so I will. And this applies, I think, not just to Maryland, but to other states. But his question is, how does Maryland engage OPLWH? I don't know what that acronym stands for, but who are not clients of Ryan White clinics, for example, those covered by Medicaid, Medicare, or commercial insurance. How does Maryland engage with OPLWH?
Older people with HIV.
Okay, thank you.
So even you don't have to be Ryan White. I think one advantage, and I'm glad I'm in Maryland, like we don't have a waiting list for MedApp or anything like that, but our older persons, mostly, if they are being treated in any of our clinics or our health department, wherever they're being treated, we have a way of communicating, and we invite to all. It's not limited to just Ryan White older adults. And I think strengthening that network over the years, because I know working with partners and those that are engaged with older adults have this passion, because we reach out, we find, where are you? If you have this, aging, we want to talk to you. And making that meaningful engagement of the person, that they have something to contribute, and mainly their story being heard about, problems that have happened, access issues, not having Ryan White, but being told that your Medicaid wasn't renewed, or there was a failure in the system, how to advocate and how to strengthen one another with advocacy. And so they do that pretty well.
Great, great.
I hope that answers.
Yeah, no, it was helpful for me. Tom, I hope that's helpful for you. So seeing no other hands raised, I have a question about engagement through the Older Americans Act, because we know that public health is now beginning to work much more closely with the Aging Services Network to address the needs of older adults. And so I'm wondering if you're aware, Dorcas, of any funding that is available, programming that's available through the Older Americans Act to support people living with HIV and aging.
Yeah, I know they're working on that. I'm not aware of anything that has been finalized. I know that we had signed on to be an advocate or to, reinforce the need to do that, but maybe somebody else on here knows about that. I don't know, but I'm not aware of funding that has been released.
We'll take a look at that as well.
Mhm.
Thank you. Mark, you want to come off mute and ask your question?
Yeah, thank you for the opportunity. Here in Spokane, Washington, we have transitioned years ago from our Spokane AIDS Network to public health, and that's where I work as a peer navigator, which is a new program, very exciting program that is really hopefully going to spread across the whole U.S. But what we've been able to do with a nonprofit like Spokane AIDS Network that continues is to develop wraparound services. So I just want to stress the importance of working with existing nonprofits and collaborating and doing what you can to, especially in social connections. So we do social groups on Saturday. We have call-ins in the evenings and during the day. It takes a lot of work, but it's worth doing because isolation and old age and COVID-19 has really impacted the community. Thank you.
Absolutely, Mark. Absolutely. I totally agree. And working with, like you said, the nonprofits, that is non-traditional organizations that can also be brought in to discuss this. Absolutely. And to be a part. And there are people that want to do that. So even though I mentioned age-friendly dementia, is that what I said?
Dementia-friendly?
Dementia-friendly organizations, and being pulled in with that group as well, because we're seeing people are concerned about some cognitive issues. People are concerned about how hearing and not having a hearing aid can impact cognition. And sometimes for lack of a better word, vanity, pride. I do not need a hearing aid. I will not have one of those, but it has helped. One of our persons has a hearing aid now, and they said, I can hear my feet going across the carpet. It has changed my whole life. And their whole demeanor has changed. It's given hope just from having a hearing aid.
Yeah.
But we had to work with other, how can we fight to get a hearing aid that doesn't cost an arm and a leg? Same with dentures, being able to eat healthy and having access to dental care. That's another whole issue. I'll stop there.
So Dorcas, we recently added a C to our 5 C's framework. So now we have a 6 C's framework. And the 6th C is creating and leading policy systems and environmental change. Right. And you are certainly, as Jane recognized in the chat, Jane Carmody from the Johnny Hartford Foundation, you certainly are a leader in policy systems and environmental change. But I wanted to note that there is, there are in some states opportunities and movements that are underway to create master plans on aging. We know that California already has a master plan. It's quite extensive and covers. It's just very comprehensive and impressive. And I know that there are other states that are working on them, but I don't know if you know, or if anybody else on the call here today is aware of whether those master plans on aging also address people living with HIV and aging. I don't know if any of our California friends are aware, or if you're aware, Dorcas, because I haven't looked at it closely enough to know.
I know Maryland doesn't have a master plan. The biggest plan we have had is having the Maryland Department of Health and the HIV planning group to finally come together and have those aging cells now. That's part of the plan to look at. But no, I would love to hear from the others, especially California with, I don't know if someone's on here that's familiar with Dr. Meredith Green. That's the director of the Compass Clinic in San Francisco. Okay.
Yeah, I'm not sure that we've got those connections made yet, but hopefully we can work on those.
Yeah, okay. We can do an email introduction, but happy to, connect you with those that I know that are in other states that are working as well. But this is like a huge issue. And it's a problem. And I saw Jane had put in the chat about vision, and I can't think of the other thing she said.
Eye care and vision care, yeah.
Yes, there.
It's so interesting. Meg and I had attended, and Dorcas had attended what I call is the International Federation on Aging, which is a World Cafe call they have on Friday mornings. And a couple of weeks ago, a gentleman was talking about eye care and trying to improve eye care in India. Now, we take it a little bit for granted here, but there is still many issues. And I thought, without your vision, you cannot. Well, I mean, I know people that are blind from birth and blind, have worked it out, but just think about older people who cannot, who cannot maneuver and cannot age well and successful aging without good eye care. So I applaud your comments about the census. It was great. Such a great presentation.
There's another really great question here from Tom. And it's what's being done to expand access to comprehensive geriatric assessments, perhaps through senior centers, retail pharmacies, et cetera.
Oh, that's a great question, Tom. I applaud you. So slowly, but this is what we're advocating for here in Maryland as well. So we just started having, first of all, geriatric assessments being done in August of last year in the Hopkins Bartlett HIV clinic. Just started last year by having a geriatrician provide consultations only twice a month. But his whole thing is, let me have the older ones, give them to me, tell them I'm here. And the older patients in our coalition, we said, spread the word. Every clinic should have it. University of Maryland also received funding through Age Positively to integrate geriatric assessments in their clinic, and that pocket guide, which I'll send to all of you, that the AATCs have, that's throughout all 8 regions and beyond. You can use that. But yes, it has to include the pharmacists, and pharmacy is on our coalition. We have 2 pharmacists. As a matter of fact, they're presenting tomorrow, Ask a Pharmacist on drug-to-drug interactions, COVID meds and vaccines and HIV meds. So we involve everyone, not a silos. You have to involve everyone, this multi-team approach. And it doesn't have to be in those clinics. You may not have a geriatrician, but making folks like their social workers aware of, let's include, hey, what resources, strong resources do we have? And what do we need for our patients that are living longer and have issues with housing or issues with needing a rail in their home? We have the Capable study that goes on at the School of Nursing. I don't know if you've heard of Capable.
Oh, yes.
Yeah, you're familiar with Sarah Santon. And she does have some patients living with HIV that have received the services as well. But that is major, having a nurse and a handyman and a little bit of money. They could use more money to come and put a ramp in or put a rail up to make the home safe so people can stay there. And the fact of, don't forget about the cognition and Alzheimer's, that piece as well. I'm moving 2 aunties on Monday, to a new assisted living facility. They had to move from the one because of expense and so forth. They're up and about, but pleasantly confused. Yeah. But dealing with that issue and I have cared for my parents down through the years. They're deceased now, but that whole issue that needs to be talked about, that can be happening with some of our patients. So one of our Friday meetings with the coalition, we had Ask a Gerontologist, and Dr. Tom the one who's seeing patients in the clinic, he came on to answer any questions and give a little bit about how to take care of cognition in your mind, and just a dear, you know.
Yeah, they're so helpful and so interesting. So Jane, thank you for adding your comment about CVS Health clinics using the 4 M's. And I'm curious, within the 4 M's, in the what matters, mobility, mentation, and medication, is there consideration for people living with HIV within that model?
You know,
Mm-hmm.
yeah, you know, I'm just going to say something quick. I wrote it down because we are working on master plans on aging. I will make sure that our program officers working that add that, Dorcas, to make sure that it is there. As far as what we would say about health equity and our work with Diverse Elders Coalition, is that what matters needs to address everybody. And so that's kind of where it starts, Dorcas, for us anyway.
Exactly. And I'll make sure you get the pocket guide, the
That would be
assessment
great.
screening tools. Yeah, absolutely.
Great. Thank you so much for sharing all those wonderful resources as well. I think we have time for one more question, if anyone has a final question. And if not, Dorcas, I just want to say thank you again so much for reaching out to us last year for the Graying of HIV conference. That was so helpful. Such wonderful resources. I think we're just getting started with our collaboration between public health and in incorporating healthy aging and HIV together. We really hope that we know we will stay connected, and we will continue to share resources, and we'll keep plugging away at this. And I just want to let everyone know that for the rest of this year, we will be focusing on social determinants of health and looking at some potentially not necessarily what we would consider among the traditional social determinants. So next month, we will be talking about technology and access to technology as a social determinant. And I think, Dorcas, what you said about food security and nutrition, I think that would be another interesting, beyond the normal traditional definition of social determinants for us to explore. So, so stay tuned for more information on that. If you are not aware of our ongoing series, our AFPHS training series, the third Thursdays at 3 p.m., you can find out more information on our website, which is AFPHS.org. That's AFPHS.org, and that stands for Age Friendly Public Health Systems. So thank you very much, Dorcas. Any final words?
Yeah, I just wanted to say one last thing. I'll make it very quick. Don't forget to also include, there's so much to include, discussing advanced directives with our patients as well, power of attorney, long-term care. And COVID has really made that even clearer. You don't have to be, anything has to happen to you, like your palliative or your hospice or you're on your way out. Do it now. I'm doing mine while I'm alive and healthy. If anything should happen to me, I don't want my family scrambling. I want them to go where I tell them to go. That's where the information is. And up to a certain date, I update things. So it's a reality for all of us. But Dr. Carla Alexander from University of Maryland, she's on our coalition, and that's what she teaches, advanced directives and so forth. So thank you. Thank you all so much for your time.
Great. Thanks so much, everyone. Thanks for being here.
Enjoy your day.